Uh, let's turn to Genny Grilli, who's the Hepatitis Unit Supervisor at the Minnesota Department of Health. Genny, welcome.
Great. Thanks so much, Dr. Ward. So, yeah, my name is Genny Grilli. I'm the Hepatitis Unit Supervisor at the Minnesota Department of Health. And I was lucky enough to start my full-time career in public health working on perinatal hepatitis B. And I'm even luckier now to supervise that work. So if we want to hop to the next slide. So I'm going to try to kind of keep it high level because Dr. Ward and Julie both covered quite a bit. So going to kind of talk a little bit more about kind of the quote unquote Minnesota experience. So as Julie said, the perinatal hepatitis B prevention program began in 1990 with the goal of identifying and treating infants that are born to persons who are pregnant and living with hepatitis B. So when we think about sort of the scale or the size of this program, and again, we're focusing on people who are living with hepatitis B and their infants and young children. So in that realm, in that kind of realm of thinking, we've got about 6,000 pregnancies that had due dates in 2022 that were followed within the program, and that led to about 6,800 infants. So that difference in numbers a little bit is multiple births. So we certainly do see multiple births in our program. But we also, that is balanced out that some pregnancies don't end with a live infant. So really that discrepancy is in that there are a lot of pregnancies that we don't hear about until the pregnancy has ended and we've got a baby. Um, so there are certainly, more infants often than we're following than the pregnancies themselves. And what that means is that we have people who are coming into the hospital to deliver and, bring their kiddo into the world. And we just have to hope that the hospital knows about that family. Because part of our work is, making sure that as many people as possible who are involved in the care of this parent-child pair are aware of kind of what's at stake in the world of hepatitis B. So in Minnesota, we send notifications to hospitals. We make sure that they're aware, but we can't do that if we don't know about the pregnancy. So let's go to the next slide. So when we look at some of our national data, we're going to go back to 2021 because we've got to give these babies time to be born, time to get their vaccines, time to get their testing, and then be able to evaluate their outcomes. So that's going to be a longer period of time. So looking back at 2021, the national average per public health jurisdiction, which is a little bit more than the number of states that are out there, because we have some large cities, we have U.S. territories. So we're talking a little bit more than 50. But the national average per jurisdiction is about 111 infants. So we have some jurisdictions that have like 3 babies a year that they follow. We have some that are, over 1,000. So quite the range. But when we look at what the timely post-exposure prophylaxis, so the HBIG and the birth dose that's given to these infants who are born to hepatitis B positive parents, how many do we get done there? That national average is about 84.5%. And then we look at how many do we get vaccinated by 12 months. That's our next sort of time point that we're really shooting for. Really, they should be completing the vaccine series at 6 months of age, but that gives them a little bit of extra time, and a little bit of grace when we're talking about how do people compare at the national level, and that's 88%. And then PVST, post-vaccination serologic testing, where we're looking to see if our kiddos are protected from hepatitis B or infected with hepatitis B. And then whether or not we actually get that even completed, where we're going to see them drop off over time. And you can see that that number drops quite a bit as well. So Minnesota, we are lucky enough to have, a really robust program. So we have providers who are very, very engaged in the work that we do. We have been, working towards these types of numbers for a very long period of time. So you can see that the vast majority of our infants get the shots that they need at birth on time. So this 99.7% represents, usually about 3 to 7 infants or so who don't get those shots in a timely manner at birth. Um, and then we have, we have very good completion of vaccine by 12 months of age. And then PVST, that testing, it drops off even for us too, even though we really do have a relatively strong program with really engaged providers. Um, and Minnesota, you might be surprised to be in one of those upper numbers, but it's really just because of the populations that we serve in Minnesota. So let's go to the next slide. So in Minnesota, at any one time, we're usually following about 100 to 150 pregnancies, so persons who are known to be pregnant living with hepatitis B. We see between 300 and 400 infants born each year into our program. Just like with the trend data that you saw for Julie's jurisdiction, we are seeing declining numbers of births. Which we, really hope is just that we've got fewer people out there with hepatitis B. But a lot of that story is about immigration into the US and how that looked over time. In Minnesota, we see about 0 to 3 perinatal infections each year. We had a very, very good run for a nice long period of time where we had no babies infected for like 5 years in a row. Hasn't been the case in the last few years. We have seen a few infections, unfortunately. But a lot of times, those instances are individuals or babies who got the shots that they needed at birth. And so we have to keep kind of digging in to be able to understand the full story of what's going on there. So a little bit of just overview about Minnesota. We're a centralized state, which means that all of our case management starts at the state and then it goes out to local public health departments. We have 2 counties that cover almost 50% of the cases, and 80% of our cases are in the 7-county metro area. So all that to say that we're a very kind of tight program in one part of the state. So if you want to go to the next slide. In Minnesota, we have a large refugee and immigrant community. We have the largest Somali population in the US and the second largest Hmong population in the US. And both of those populations are disproportionately impacted by hepatitis B. So these are kind of, it's the pieces of the story to understand about why Minnesota has so many cases. But these are very tight-knit communities too. So, it's targeted educational outreach events and things like that really can go a long way because they are tight, close-knit communities in a small geographic area. So again, just some more data where you can see that, we have a lot of racial groups presented here, but primarily our Asian and our Black populations are disproportionately impacted. And we assume that the vast majority of those are born outside the US. Foreign-born populations, non-US born populations is 61%, but with a huge, huge number of people where we don't know where they were born. So of the people we have information about where they were born, 95% of them were born outside the US. So as we see changing trends in immigration over time and refugee populations coming in, it's really important to know where they're coming from and, what the risk of hepatitis B is in the countries where they themselves were born. So if you want to hop to the next slide. So in Minnesota, again, just kind of trying to center us as we think about some of our numbers here. We have about 28,700 people living with chronic hepatitis B. If you want to go to the next slide. We can see what those racial disparities look like when we graph them in a way where we can talk about them side by side, which is by looking at the rates per 100,000 persons. So again, just another thing to show hugely disproportionate impact on our Asian Pacific Islander communities and our Black and African American communities. So it's really important that we have all of this as we're thinking about the realm of hepatitis B, that we know who our communities most at risk are. But it doesn't mean that our work stops there. So let's go to the next slide. So we know that when we're talking about the realm of people living with hepatitis B, that without proper post-exposure immunoprophylaxis, which means without our babies getting those 2 shots at birth, when they're born to a hepatitis B positive parent, about 40% of those infants will become infected with none of that care happening. It's much better if they get one of them. Obviously, much, much better if they get both of those shots. So this is the best worst statistic in my world is that the risk of parent to child transmission is 10 to 90% if those shots are missed. So again, best worst statistic because that's almost all the percents and really doesn't help as we think about risk. So I say that to also kind of ground us in conversations that we have with parents where there is a hepatitis B positive pregnant person. Some of those conversations are difficult, and we do even see families who are hugely at risk wanting to skip those shots. And because we've got this terrible statistic in front of us that doesn't help us really understand without additional testing what the risk is for these infants, it makes it really difficult to have these conversations, even in instances where we see individuals who are at incredibly high risk of passing this infection onto their infants. We absolutely do have persons living with hepatitis B who refuse these shots for their infants at birth. And we know that there is a risk of infection there. So you can all imagine how it is to have these conversations with individuals who know that they don't have hepatitis B. And when we center it, only around birth, instead of talking about the fact that second an infant leaves the hospital, they're at risk in the larger world that they live in, household members, anything like that. It makes it really, really difficult to have these conversations. And so we know that the risk of transmission is incredibly low when we get these kiddos the proper shots. And I don't have slides because these are really anecdotal stories because they're before my time, but we do have two very noteworthy instances in Minnesota where we had infants that were born to hepatitis B positive parents. In one instance, we knew the birth parent had hepatitis B and the shots at birth were missed. That baby ended up going into liver failure. Thankfully, as best as I can tell, again, it predated me, but as best as I can tell, they did recover. I'm not sure whether or not they ended up needing a liver transplant at a very young age. Our other kind of instance that is really at the heart of our work, we had an infant that was adopted from the South, so geographically not close to Minnesota. And they were born to a hepatitis B positive parent, but because it was an adoption situation, it just wasn't caught. And this wasn't, many years ago, it was some years ago, 2009. So may feel like a long time for some of us, but in 2009. And unfortunately, that infant, again, was not identified as being at risk. They didn't receive shots at birth. And at 9 months of age, that infant went into fulminant liver failure and they passed away from hepatitis B. And so those are really short-term immediate impacts, and we absolutely can see long-term impacts as well. We expect that infants who acquire hepatitis B, especially early in life, will go on to have, much more negative health outcomes. I believe the statistic is that 1 in 5 will die prematurely from their hepatitis B infection. And that may not be at 9 months of age. That might be at 30 or 40 or 50 years of age, but it is a shortened life for that individual because of a very preventable disease. So if you want to go on to the last slide here. So we know how to prevent hepatitis B in the world where we have parent to child transmission. We've got a program that's been in existence for decades. We've got people like Julie who have been doing this work for 20 years and know how to do this work. And they know all the people in the game at the hospitals and clinics and things like that. But we also, have this whole other world where we have infants who are born in these situations where we could see misinterpretation of test results. We could see maybe the birth parent being negative or other members of the household being positive. Just a misunderstanding of the risks around how hepatitis B is transmitted. And so it's just vitally important that we get that birth dose done for families. So we have worked, with hospitals in Minnesota assessing what their birth dose rates are. We find that they're actually relatively decent, and that when we do see some of the lower numbers, it's often because of documentation errors and things like that. So, some of these gains may feel very small in some ways because some hospitals are really knocking it out of the park pretty well. But we really do have to focus on those areas where, even though it's maybe small gains, anything to get our birth dose rates up by a little bit. So even in hospitals that are performing really well, trying to find where those gaps are. And especially if we're seeing a lot of refusal or folks who want to wait to do that first dose of vaccine, really making sure that we're having the conversations. And I also want to note chronic hepatitis B surveillance is not funded at the national level. So what that means is that we're relying on public health jurisdictions who are not adequately funded to do everything that they can to find individuals living with hepatitis B, and check whether or not they're pregnant and then enroll them in the program. So doing a lot of that work, when we don't have the funding for that first step of finding hepatitis B, makes it very, very difficult. So I will end with one more little anecdotal story that, in true public health fashion, is actually about my own kids. So for my first pregnancy in 2015, I refused the birth dose because I knew my own risk. I knew where my kiddo was going to be. I knew about family members who we are all very engaged in healthcare. So I knew what was going to be surrounding my child. And so I said, we're not going to do it. And we're going to see what conversations happen because I love very close to me case studies. And no one talked to me about birth dose. dose. So I stated it early in my pregnancy, you know, I think we're going to delay. I think we'll wait to her first pediatric visit. Stated it in the hospital, and there was never a conversation that occurred. For my second kiddo, we got her birth dose in 2018. But, you know, a similar scenario, very, very little conversation around, you know, the fact that that was a decision we would have to make, and any, you know, guidance around how to make that decision. And so, you know, it really goes to show that we have a long way to go. I hope I'm done with kiddos, but I hope, you know, 10 years out from my first kid that we are in a better place. But we also do know that there is a lot of work left to do here. So I will end there and pass it off so my hospital colleagues have a chance as well. Thanks so much.
Thank you, Jenny. A great overview.